Welcome back to CLOT Conversations, the podcast where we cover some of the latest work in the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada. I'm thrilled to be joined once again by one of my co-hosts, Dr. Jamil Abdurrahman from Toronto General Hospital. Get ready for another insightful discussion. Thanks for being a listener.
In this episode, we will be discussing another publication covering recent research in cancer-associated thrombosis, this time from the European Heart Journal, Predictors of Recurrent Venous Thromboembolism and Bleeding in Patients with Cancer, a meta-analysis. We're pleased to have one of the authors join us today, Dr. Faizan Khan.
Dr. Khan completed his PhD in clinical epidemiology at the University of Ottawa in October 2022 under the direction of Dr. Dean Ferguson and Dr. Mark Roger. His doctoral research focused on determining the optimal duration of anticoagulant therapy for patients with unprovoked venous thromboembolism and earned him the Governor General's Gold Medal. Currently, he's a CIHR Banting postdoctoral fellow at the University of Calgary, researching acute treatment and long-term prevention of stroke under the mentorship of Dr. Michael Hill. It's great to have you here, Dr. Khan. Thank you for participating in our podcast, and let's get started. I'm going to start by asking you, why is predicting the risk of recurrent VTE and bleeding in those with cancer-associated thrombosis important?
Right. Thank you so much, first of all, for the invitation. It's a pleasure to be here and discuss our systematic review and meta-analysis. So, as you know, patients with cancer-associated venous thromboembolism generally have a poor prognosis as compared to patients with cancer and no VTE, and that includes increased risks of both recurrent venous thromboembolism and bleeding. And current guidelines, as we know, recommend at least 6 months of anticoagulant therapy for patients with cancer-associated VTE. But one of the major areas of uncertainty when it comes to anticoagulation management in this patient population is that the duration or the optimal duration, as well as the intensity of anticoagulation, is unclear. And that decision requires, careful balancing of both the risks of recurrent VTE as well as the risks of anticoagulant. And so the question is important because it informs, management decisions for this patient population.
Okay, so you conducted a systematic review and meta-analysis to identify the predictors of recurrent VTE and bleeding in those with cancer-associated thrombosis. What kind of studies and which participants did you include?
Right. So, Jamil, just to provide some context of why we did a systematic review and meta-analysis in the first place from a methodological perspective, is that we know that this clinical decision-making requires identifying which patients are at the highest risk of recurrent VTE and which patients are at high risk of bleeding. And what we noticed in the literature in the first place is that this identification of these patients is challenging. And the main reason for why it's difficult to identify these patients is that there's limited or inconsistent data on prognostic factors. So while there are risk scores or risk schemes that have been proposed to predict these clinical outcomes in patients with cancer-associated VTE, those scores and these models only perform modestly at best in identifying these patients, and they also lack adequate external validation, which limits the use of these scores in practice. So we knew that there's a lot published from individual studies that gave us some clues about which factors may be associated with these outcomes. But really, from a methodological perspective, and as you know, systematic reviews are needed to inform guidelines for clinical practice. We wanted to gain a comprehensive and an evidence-based understanding of all the key factors and which are the perhaps the most reliable factors that must predict these outcomes in these patients. So that was the rationale for conducting a systematic review and meta-analysis rather than a separate individual study, like a prospective study or so on. So with that context, our systematic review meta-analysis essentially observational cohorts, both prospective cohort studies as well as retrospective cohort studies, and randomized controlled trials were eligible for inclusion as long as they included patients or adult patients with VTE and cancer, so patients with VTE in active cancer as defined by the ISTH criteria or as defined by the individual studies. And they had to evaluate prognostic factors for both recurrent VTE or anticoagulant-related clinically relevant bleeding in these patients. And clinically relevant bleeding was also defined according to the ISTH criteria or as defined by the individual studies. So that was the overarching sort of eligibility criteria of our systematic.
So what studies did you end up including in the systematic review, and what was the risk of bias in these studies? Can you give us an overview?
Yeah, an overview. So we just following guidelines of conducting systematic reviews of prognostic factor studies, it is recommended that ideally you want to meta-analyze or pool studies that provide you with prognostic effect estimates that have been adjusted or accounted for other confounding variables so that you try to get at an independent effect of the fact. So when we were designing this, we actually included studies that provided us with adjusted prognostic effect estimates. Those come from a multivariable model that includes confounding variables as well, and unadjusted prognostic effect. And so for the purpose of our discussion, I guess we can focus on the studies that we included in meta-analysis of adjusted prognostic effect estimates. And the summary measure that we focused on, primarily due to the availability of data, was hazard ratios. So when it comes to studies that evaluated factors for recurrent VTE, we included 26 studies that provided us with adjusted hazard ratios. And when it comes to clinically relevant bleeding outcome, we included 12 studies that provided us with adjusted hazard ratios. I just want to clarify here that we considered prognostic effect estimates to be adjusted if the multivariable model included at least one of the established factors that has been associated with these outcomes. So when it came to the outcome of recurrent VTE, the multivariable model had to account for at least sex, age, history of VTE, site of VTE, cancer site or cancer stage, as these are known to be established for recurrent VTE. And when it came to our analysis for clinically relevant bleeding, the multivariable model had to account for at least age, history of bleeding, cancer stage, cancer site, or cancer third. So those were the studies we included. With respect to risk of bias, there were some studies that were at moderate risk of bias. I think the primary concern for most of the studies that were deemed to be at moderate risk of bias was inappropriate or not adequate adjustment for confounding variables. So that was one of the key things when it came to risk of bias.
Okay, so let's move on to the results. Which risk factors did you find are associated with recurrent VTE?
Right. So again, I'll focus on the risk factors that we identified that were associated with, adjusted from our adjusted analysis. And before I go into that, I wanted to point out that one of the key things that we incorporated into our analysis is the use of grade and the grade methodology. And what that allowed us to do is to contextualize our findings with respect to the underlying risk of bias of the studies, or the inconsistencies or the imprecision in the estimates, the indirectness of the estimate, or any potential publication bias. So we sort of rated the confidence in the prognostic effect estimate that we got based on limitation in these domains that I mentioned. So we focused our analysis or our conclusions on findings that were associated with high certainty association according to the grade methodology. So when it came to the outcome of recurrent VTE, then factors that were associated or had high certainty association with the risk of recurrent VTE included history of VTE, recent surgery, which was actually associated with a decreased risk of recurrent VTE, ECOG performance status of 0 or greater than 1, advanced cancer, which included metastatic disease or stage 4 cancer, breast cancer, which was associated with a decreased risk of recurrent VTE, lung cancer, hepatobiliary cancers, pancreatic cancers, and cancers of the GU system. So those factors were associated with recurrent VTE. And then factors with high certainty association that were associated with anticoagulant-related bleeding included history of bleeding, an ECOG performance status score of 2 or more, advanced cancer, brain cancers, GI cancers, GU cancers, and pancreatic cancers.
Interesting. Can you tell us some about the strengths and limitations of the study?
Right. So I would say I'd mentioned two key strengths. I think one strength is our comprehensive search for all relevant studies that included prospective, retrospective cohorts as well as randomized controlled trials. So we were actually able to obtain and include adjusted prognostic estimates from all the major randomized trials that assessed anticoagulant therapy for cancer-associated VTE. That included the CLOT trial, the CATCH trial, the HOPE-SI VTE trial, as well as the Caravaggio and Canvas trials that were recently published. So that's one strength. And the second strength that I mentioned is particularly our use of the grade methodology to really contextualize our results.
Great.
Limitations you asked as well. I would say one of the limitations, obviously, owing to the limitations in the evidence base, is that we could not meta-analyze other factors that have been reported with the risk of recurrent VTE bleeding or biomarkers for that matter, for example, D-dimer or tissue factor, or other comorbidities or other cancer sites that we just could not study, either due to an insufficient number of studies evaluating these factors or due to the inherent limitations in the source studies. There was just too much variability, for example, in studies that evaluated biomarkers or D-dimer levels that used different thresholds, different cut points, different assays. So from a methods and meta-analysis perspective, it was difficult to combine them. So I think that would be one of the major limitations. And then other limitations is that we could not account for any effect modifications. How do the identified prognostic factors behave, or how does their effect change with respect to other characteristics such as male versus female, and different cancer sites or different cancer stages? So that's all sort of highlighting the need for future research in this area.
Thank you. Oh, sorry. Next question to me. Sorry.
Oh yeah, go ahead.
So how will your findings affect clinical practice in those with cancer-associated thrombosis?
Right. It's a great question, Jamil. And I would say our hope or our intent of conducting such an analysis was really to lay the groundwork for a more risk-adapted and individualized approach to anticoagulant management or anticoagulant treatment of patients with cancer-associated VTE. So I think focusing on some of the high certainty key prognostic factors, I think clinicians can use these factors to inform patients of their expected prognosis. That's first. And second, they can use these key prognostic factors and incorporate them into shared decision-making discussions with their patients to collectively decide the optimal duration and intensity of anticoagulant treatment. For example, patients at high risk of recurrent VTE and low risk of bleeding may potentially benefit from a longer, for example, minimum of 6 months and more intense treatment. So no dose reduction of bone like would happen after the first 30 days. And then on the other hand, patients with low risk of recurrent VTE and high risk of bleeding may potentially benefit from a shorter duration, maybe 3 months, or a less intensive anticoagulant regimen.
Okay, perfect.
So what are the next steps and what further research is needed in this area?
Yes. So next steps, as you may already know, one of a CHR-funded prospective cohort study called the CAN-CATCH study is currently ongoing to develop risk stratification models for both recurrent VTE and anticoagulant-related bleeding in patients with cancer-associated VTE. So very targeted and specific research question that we hope will incorporate some of the factors that we identified in our meta-analysis and will validate the reliability of the factors that we identified. And then future research can also improve the predictive performance of existing risk scores that I mentioned to Jamil earlier on, to improve their predictive performance by validating them by including some of the factors that we included. And then the third research area would be, of the factors in our analysis that were not associated with high certainty of evidence, but perhaps associated with moderate certainty of evidence, those factors need to be validated further so that their certainty or our confidence in their prognostic effect would be increased. And then evaluating the factors that we identified in a broad range of patient subgroups and across patient characteristics would really inform clinical practice.
Well, that's great. And before we go, is there anything else that you'd like to discuss that we haven't touched on yet?
No, I think we covered great questions. I think we covered all grounds.
Okay, great. Well, it's been a pleasure having you part of our podcast today. Thanks for joining us. It's great.
My pleasure. Thank you so much.
And thank you to our audience for joining us on CLOT Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. This is our 45th episode, including a great collection of discussions from the recent ISTH meeting with Canadian researchers that you may want to check out. Want to stay up to date on the latest in thrombosis? Hit the follow button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference coming up this fall. Your support matters. Consider donating to Thrombosis Canada to help continue the fight against thrombosis. And don't forget to check out the program notes where we'll have a link to the publication that we were speaking about today. Thanks again, guys.
Right. Thank you so much. Thank you. Thanks, Jamil. Bye-bye.
Awesome. See you later.
Jamil?
Yep.
Just want to have a quick chat about something. That offer from Thrombosis Research for the publications.
Yep.
You asked them about cost?
That's a good question. So Thrombosis, I think, let me just confirm on the email, but usually it's because he worded it as an invitation to submit for narrative review. He didn't mention anything. I'm assuming it would not be open access cost, I think. But that's a good question. I should, just pull that email.
If we can find out if there's any cost involved, because I don't want to have surprises at the end.
Agreed. Yes, agreed. 100%. Yeah. Let me look at the original email. Okay. Cover. No, it never specified. Let me reach out. You're right. It's a good thought, just to be sure. Because good thought.
Okay.
I'm glad you thought about that. I did not think about that. I just assumed, but you're right. We should confirm.
Yeah. I just like to make sure because most of the publications we've been involved with lately have had some sort of cost involved with them. So
okay, that's not as fun. Okay, I'll send that email now. We'll figure it out.
All right.
Cool.
Thanks a lot.
Otherwise, audio is good?
Yeah, I think so. It's so I just was I've been working on the editing of the Dragon's Den, and the interview that you did with Emma came across really well. So
good.
I think it's probably good. So we'll keep going this way.
Yeah.
All right.
Perfect.
So next week we have another one next week on Thursday.
On Thursday.
And that's the one.
I don't have in my calendar. I'll be able to do it, no problem. But if you can just send it to me so I have it in my calendar.
Well, maybe I haven't sent the Zoom yet. I don't know. That's
right?
the one. That's the one with Dr. Parvizzi. So.
Oh yeah. Okay.
Yeah, we haven't set a time for that. You said it was good in time, right?
Okay. Yeah. Right now my day's open. So yeah, whenever, fine.
Okay, I'll Holly's been the one corresponding with him, so I'll get her to send him a note.
Perfect.
And figure out. I mean, I'm good for any time on Thursday as well. Yeah. So
perfect. Awesome.
All right. Have a good one.
Yeah, you too. All right. Talk to you later. Bye.